Good afternoon and welcome to the September installment of the Virginia Hospital and Healthcare Association's 2019 High Reliability Organization Brown Bag Webinar Series. My name is Abraham Segrist and I'm the Vice President for Quality and Patient Safety here at the VHHA. On behalf of the VHHA's Center for Healthcare Excellence and the Virginia Patient Safety Organization, I would like to welcome all of our colleagues from across the Commonwealth to today's webinar. Now in its third season, this monthly webinar series features successful strategies from Virginia hospitals and health systems promoting safety culture and high reliability in a variety of clinical areas. I'm glad to present to you today our colleagues from the Inova Health System in Northern Virginia and their presentation titled SOS, Spotlight on Sepsis at Inova Mount Vernon Hospital. And our presenter today will be Mr. John Lawrence, Sepsis Coordinator at Mount Vernon. Next slide. I'm going to ask my colleague John if he can move us to the next slide. I'll review some housekeeping messages and then I'll turn it over to John. So use the arrow down button, John, and we'll move forward to the next slide. There you go. So the slides for today's presentation were sent this morning via email. This webinar is being recorded, so you'll be able to access the content on our website at the VHHA in about a week. All participants are in a muted mode right now, but we encourage you to type your questions into the chat box. And I'm going to try something a little bit different today, just to make sure folks can actually use the question or the chat function. If you can go into that box and just say hello from whatever town or city you're calling in from across Virginia, I just want to make sure that that feature is working. So as you all do that, my final comment will be that at the end of the webinar, there will be a 3-question survey that will be launched that will ask for your feedback on today's webinar. And so I am looking to see if anyone has typed in hello from where they are. And I'm going to actually check a different box. Yes, there are folks who are typing in, so wonderful, it's working. So John, I'm going to go ahead and turn the webinar over to you, and we will hear about the great work going on at Inova Mount Vernon with sepsis.
Good afternoon, everyone. My name is John Lawrence, and happy first day of fall to you all. I am the RN Sepsis Coordinator at Mount Vernon Hospital in Alexandria, and I've been in that role for just about 3 years. So we're looking forward to sharing our sepsis journey with you all today. We are a 237-bed hospital in Northern Virginia, Fairfax County, and we offer our patients convenience and state-of-the-art care in a unique healing environment. And so this is a brief outline of our talk today. So first I want to talk to you about our opportunity that we identified and then what we've implemented to improve our sepsis outcomes and our results and next steps. So about 3 years ago, we got this report from our quality department, and we saw that within our 5-hospital health system, we were struggling with sepsis mortality. And so this is a risk-adjusted score, and we were not meeting our target, and we were not performing very well compared to our other hospitals. And we found this interesting because when you compare the number of beds that we have, which is that dark blue diamond, we actually have a few hospitals with fewer beds, and yet their sepsis cases far exceeded ours, and yet our deaths were the fewest in the system. And so we felt that our sepsis patients weren't actually getting represented in our coding. And furthermore, our Sepsis 1 bundle compliance, which really reflects the quality of the care that we're delivering, was the lowest in our health system. So our mortality was the highest and our sepsis compliance was the lowest. So we worked together, we collaborated. We already had a sepsis committee in place. So the various leaders and myself really started a full court press to tackle sepsis. And I just want to share some of the success factors. And number one, we had executive sponsorship from the very beginning from our CEO, our CMO, and our CNO. And then that trickled down to the different unit leaders and the medical directors for both the emergency department and our inpatient floor. And so that's invaluable, and they really have empowered us as a team and offered accountability and encouragement. Second, I want to recognize our Inova Health System for conducting a 90-day clinical effectiveness sprint at the end of 2016. And I'll share some of the things that came out of that sprint. But they had a great leadership and great sustainment that was in the form of a biweekly call for a whole year after that sprint, where we continued to talk about how to implement this and what our barriers were. And then our leadership did recognize the importance of having a dedicated sepsis coordinator, and they've allowed me in about a half-time role to focus on sepsis. And although my official title is sepsis coordinator, I do share that with other responsibilities, and it does come out to about half an FTE. And again, we have about 237 beds, and this has seemed pretty doable and really has met the need. And then we do provide real-time focused feedback and education, and I'll explain more about that in a bit. And then we've tried to follow the principles of a high reliability organization. So first of all, staff education has been really important, and that came out of our sprint as well. And we've incorporated that into our annual skills fair for both nurses and clintechs. Every new clinical employee gets 30 minutes focused on sepsis during their orientation. We provide ongoing coaching to frontline staff anytime we identify an opportunity, and that does come in the form of recognition as well. And then all new providers, so our physicians, our NPs, our PAs receive sepsis orientation when they come on board. We've also implemented standardized tools, and here are a couple that our nurses rely heavily on. You see the pink sepsis checklist, and we've branded everything pink in line with the World Sepsis Day. And so this checklist is available to our nurses in triage when they screen patients. It's on every crash cart throughout the hospital because those rapid responses are often related to sepsis. And so this tool is used quite a bit. We've really hardwired it, and it's really taken those 100+ pages of the core measure and put it into one page in a way that's easy for the nurses to process and to make sure we're meeting each bundle requirement. And the sepsis badge buddy on the left there is something that we've given every nurse, and it just kind of again takes the checklist and summarizes it and puts key information, including phone numbers to reach out to the critical care department, and then as a backup, our telemedicine department. So this has really ensured that our patients receive standardized care. Sorry, the slides are a bit lagging here, so we'll get to the next slide. Okay, and we provided this standardized care to our providers as well in the form of order sets and order panels in Epic, which is our EMR. And I have to say that our emergency department especially uses this very proactively for anybody that is a potential sepsis patient. So pretty much everyone with an infection that's meeting the SIRS criteria is going to get a lactic acid and blood cultures. And then if they're potentially ruling in, they're obviously going to get broad spectrum antibiotics. And we've actually standardized that antibiotic selection by potential source, UTI, respiratory, intra-abdominal, and so on, so that the patients are getting the best antibiotic selection for their source. We also, out of the sprint, were offered 24/7 support from our EICU, which is telemedicine. and it services all 5 hospitals. Primarily, they service our ICU units for after hours, but they offered their nursing service 24/7 so that any nurse in our hospital can call EICU at any time of day to have them look at the chart and to get that feedback and coaching, and that's been tremendous. And we've moved that resource more and more locally and put that responsibility on our critical care nurses, but EICU continues to be a backup resource if the critical care nurse is unavailable. Another thing that we implemented last November was the modified early warning score, which is based off of vital signs and level of consciousness, and this is how it's scored. And really what's beautiful about Muse is that in Epic, it's calculated automatically. So it takes these vitals anytime a nurse or a ClinTech enters them and automatically generates a score. And in Epic, it's a color-coded system. So green means the patient's vitals are stable, yellow, orange, and red increasingly less stable. And so we have these actions so that nurses can escalate and increase their monitoring based on the color. And for a patient list, it would look like this. And so you see on the left-hand side, there's the Muse. Red would mean that patient not very stable. And in fact, when you look at the vital signs over here, pulse is 115, respirations are 30. And so that automatically is alerting us just with a color that this patient is someone we should focus on. And nurses are actually on the inpatient units, for anybody who's orange or red, they are reaching out to our CCU nurse for a consultation about whether they need to call a rapid response or whether that patient needs a higher level of care. And that partnership has been really exciting to see. For focused feedback and recognition, we provide a monthly dashboard to our nursing unit so they can see their performance. So for example, the emergency department can see their trend with how they're doing with the bundle compliance. And so we do provide that on a monthly basis. Although if we identified a fallout, we review our charts concurrently, we would escalate that as soon as possible. But this is just a nice way for them to get a gauge of how they're performing. And we do the same thing for our physicians. I've taken out on the left our provider names and MRNs, but this is actually an unblinded list of physician names and the medical record numbers so that physicians can see how they're performing with the bundle. And recently I've included a notes column so that I can explain to them why they fell out. And this has actually generated a lot of discussion, a healthy sense of competition among providers. And then they reach out to me if something doesn't quite make sense. And it has really enhanced that collaboration and understanding of our goals with the core measure and with the bundle. I mentioned earlier that our focus feedback does include positive feedback. And so every month we recognize a sepsis star from our nursing staff. And we usually do it in the form of a case study. And so the next slide shows an actual case that we went over to show how the nurse recognized sepsis and how that nurse escalated it and got things in place. And that's been really exciting to see how this actually makes a difference. It actually saves patient lives, and we want to recognize that great work that the frontline staff are doing. Another thing that's been important for us in our process improvement is using a multidisciplinary approach. This is the two guys on the outside are part of our clinical documentation improvement team, and this is our former chief medical officer and myself. And we work together to really improve our coding of sepsis. And this next slide shows some focused education we did with our providers. I started out the presentation explaining how we were really struggling and how we were really under-documenting and underrepresenting our true sepsis population. And so we included this report, which is our PEPPER report, that shows that, you know, the green is the 20th percentile, red is the 80th percentile, and we were clearly underdiagnosing sepsis. And so we really encourage the physicians, if the patient was meeting the clinical criteria of sepsis, to document that, and even to say things like potential sepsis or probable sepsis. And that's really helped increase our number of sepsis diagnoses because we're treating these patients more or less as septic patients with standardized care, and we need to get credit for the good work that we're doing there. Another aspect of our multidisciplinary approach has been palliative care, and we've really leaned on them more and more, and we even have now inpatient hospice beds that are licensed. And so our palliative care team is responsive, and we're screening patients on admission and making sure they get those consults, especially in those cases where patients have chronic diseases like heart failure and kidney disease, where they might be needing potentially to get fluid resuscitation, but you're put in that difficult position, and palliative care really helps us in those situations as well. I'm not going to go into detail on this slide, but just to point out that we really have embedded the high reliability principles into our process. So I've mentioned that every core measure fallout we look at, even if it's not sampled by quality, we're looking at it as an opportunity. And we're concurrently reviewing our charts, and during off hours, our nursing supervisors are helping monitor that Muse score to see if there are patients that need escalation. And so really, I think the big takeaway here is that we really look at every single case as an opportunity, and we try to do that in real time. We also have worked with our community partners, and HQI, as we started the Stopping Sepsis in Virginia, reminded us that the line of communication between the hospital and the nursing home is critical in reducing admissions and mortality. And so we have reached out to our #1 referrals and done site visits with them, and they've come to us. And now we host a continuum of care collaboration. We call it our CCC, and this includes SNFs, ALFs, home health, and more. And we really started this with sepsis, but now it's broader than that, in looking at how are we improving our handoff communication and that collaboration. And then they do participate in apparent cause analyses that we do for readmissions. So the SNFs and the ALFs are calling in so that we can debrief these cases together, and this has been really tremendous. So I want to talk about our results, and I showed you that Pepper report earlier that showed that we were underdiagnosing sepsis, and you can see now for well over a year now we're falling nicely between the 20th and the 80th percentile, which means we're right on track for our sepsis diagnoses. And then in terms of mortality, the green line represents the red line represents all sepsis mortality, which is a risk-adjusted score, and you can see that coming down nicely. And then the green represents just severe sepsis and septic shock. So really both, we've seen a significant decrease in mortality. And the blue line is our bundle compliance. And so that's gone up and our mortality's gone down. And it's hard to say that it's causation, but I think there is some relationship there between our bundle compliance, which I think as we focused on the core measure, what it's probably done more than anything is served as a catalyst to bring our team together, to talk, to collaborate, to communicate. And that's really driven down the mortality. And as you know, sepsis, SEP1 is reported publicly on Medicare.gov, and this is from our hospital compare page showing that Mount Vernon Hospital, we're performing very well. So very different than 3 years ago when we were in the 40% range. Now we're 87%. And so this has really been a great journey. We've made a lot of progress. And then even though we've increased our sepsis diagnoses, we've kind of increased that pool of potential patients that factors into our mortality. When we look at actual observed deaths, we've been seeing fewer and fewer. And this is not even risk adjusted, this particular graph. This is just a raw mortality, but we've seen fewer and fewer deaths, which I think has encouraged us that we're not just, padding our numbers, we're actually impacting the care delivered, which is impacting the patient's outcomes. This does show our readmission rate, and that's come down nicely, which I think again speaks to that partnership and the collaboration that we have with our community partners. And to finish out, I just want to talk about next steps, because one of the high reliability principles is that sustainment, and we want to maintain our numbers, our core measure compliance, and our mortality, and really not just plateau, but take things always to the next level. We obviously want to continue our relationship with our skilled nursing facilities to reduce readmissions. And more recently, we've tried to focus on reducing complications. And so we use Premier Quality Advisor, and we ran a report recently to look at complications for sepsis, especially with a focus on fluid overload, because that is a concern when you're using the weight-based fluid bolus. And when we did a peer comparison, we see that we're converging nicely with our peers in terms of complications. And so obviously we want to save patients' lives, but we also want to look at complications as an outcome measure to make sure that we're reducing ICU stays, we're reducing fluid overload, so that our patients that do survive are having improved quality of life. And then lastly, coming out of this last phase of our grant with the Stopping Sepsis, we were encouraged to take a look at patient and family education. And so we've started to provide this card that was suggested to us by VHHA. And so the Sepsis Card is quite nice. It has the acronym TIME, so temperature, infection, mental status, and extremely ill. And so we're starting to give this to our sepsis patients and to teach them what sepsis is and then what they need to watch for. And so we've started on one unit, our intermediate care unit, but we'd like to really roll this out to all units and all admissions if possible, because sepsis can affect anybody really at any age. So we think that's important for public health. So we're going to continue doing that. And I just want to thank you and thank VHHA for the opportunity to share. And we look forward to hearing your questions.
Well, John, thank you very much for another excellent presentation. Great work going on there at Inova Mount Vernon. I will ask our participants, if you do have a question, that box where you all typed in the hello message, feel free to type in any questions you might have for John. And we've got a couple of minutes left, so you will have an opportunity to respond to those questions. John, as we wait for a question to come in, can you maybe talk a little bit about the engagement with the nursing homes and the level of receptivity and how that's been going?
Yeah, I'll have to say it's a very transparent and trusting partnership. And what I mean by that is it's not a blame, it's a blame-free sort of discussion, especially in our apparent cause analyses. The focus is on process, not people. And so we're very transparent, not just about the ways we think maybe the nursing facility could have done something better, but the ways that we could do something better. So I feel like that has really allowed people to open up, and they really have the sense that we're working together and we're doing this for our patients.
Gotcha. Excellent. Excellent. And one other question on this, I don't see any questions coming into the chat box yet, so we'll give folks another few seconds. But you talked about the provider feedback you all were developed and implemented, giving feedback to your docs internally. Was that generally well received? Any significant pushback from the docs, or just overall good engagement?
Yeah, I would honestly say overall good engagement. And I think that speaks to how our medical directors have interacted with the core measure and with sepsis in general. They are very supportive, and they expect that of their staff. And so I've been pleasantly surprised. I have questions sometimes, and I have furrowed brows sometimes, but it really does, it's been a really great, even though I'm a nurse and I'm talking with physicians, I feel like there's a nice, respectful engagement on that. And I always try to approach it and also get the physician's perspective, and they always have valuable feedback as well in terms of how we can communicate better, the expectations, or maybe ways that we can improve the care that we actually deliver. Because you want to treat the patient, not the core measure, and sometimes those, unfortunately, are at odds. So I think that understanding has helped as well, that we're not just all about the numbers. We really want to deliver high quality care.
Excellent, excellent. And one final question from me and Joyce here at the VHHA. The last piece you covered in terms of the patient family education, I know you said that's sort of your next step, but you have any sort of preliminary insights into how that's going? Any engagement from patients and families, or is it too early to tell yet?
I would say it's too early to tell, but I think, I used to work with the stroke program, and there's there can always be more awareness, but I feel like there's a good solid awareness of what stroke is, and the FAST acronym has really helped. And, sepsis, arguably the impact is much larger. Certainly the volume of sepsis patients at our hospital is triple our stroke patients. And so it just makes sense that patients know and their families know what to look for. And so I don't have any data to share quite yet, but we do think that this is really important. And like I mentioned earlier, we'd really like to see this rolled out to all patients. We're focusing just on patients with confirmed sepsis diagnoses, but we'd really like to be proactive and educate people even who are here for other disease conditions.
John, this is Joyce Daval here at the VHHA, and actually the acronym time that you've done for your patients and family education is actually quite very timely. It's a good acronym for people to understand, just like with stroke, that there's a need for us to jump on this thing, not wait around. And if we overcall it, so be it, but at least we've given it, the best approach possible. And I'm glad to see that you've utilized those tools from the Sepsis Alliance to implement in your facility. So great job. And I certainly want to thank you because in recognition of Sepsis Awareness Month, this has been a very appropriate presentation. And I hope folks will feel comfortable to reach out to you to ask, because I know you've been so helpful with some other our hospital colleagues. So thank you so much, John.
Yes, John, thank you for a wonderful presentation. And although our audience was kind of quiet with the chat box today, John has been very responsive to us here at the VHHA when we've asked him to give these presentations. So I suspect that if you'd like to connect with him afterwards, he'd be very open to that. So feel free to reach out to him or to us here at the VHHA. And then before we go, our final webinar of this series for 2019 will be held on Monday, October 28th. Our presenter will be Dr. Ahmed Bashist, who's the Senior Vice President and Chief Clinical Officer at Ballad Health in Southwest Virginia. And Dr. Bashist will deliver a presentation titled Fighting Hospital-Acquired Infections, Ballad Health's 30 in 90 C. diff story. So we look forward to having all of you with us next month. And we'll go ahead and end today's webinar. And please take a few minutes to respond to the survey, and we look forward to having you all with us next month. Have a great day and happy fall to everyone across Virginia.